abdominal aortic aneurysm rupture is the 13th leading cause of death in the United States. During this live webcast, surgeons from Baptist Hospital East in Louisville, Kentucky will perform an endovascular abdominal aortic aneurysm repair with the Gore Excluder bifurcated endoprosthesis. This device is designed to be a minimally invasive treatment option for patients with abdominal aortic aneurysm. The expected outcomes of this new treatment option include decreased procedural times and shorter hospital stays. At any time throughout this program, you may email questions to the physicians by clicking the M Direct Access button on the screen.
Hi, and welcome to Louisville, Kentucky. I'm Dr. Matt Young with Surgical Care Associates, and we're here live at Baptist Hospital East. We are going to be performing an endovascular aneurysm repair using the Gore Excluder stent graft today. This case will be performed live, and we'll actually be asking for questions live from the viewing audience. We already have had some emailed in, so please feel free to join in directly. Today's case will be performed by my fellow physicians, Dr. Herman Kaepnick, Dr. Elizabeth Rachel, Dr. Dean Wickel, and with Dr. Thomas Bergamini. In our group, we form Surgical Care Associates. We have close to 1,000 endografts placed in patients in the Louisville and Kentuckiana area, and are the longest running endovascular program in this area of the country. We work primarily at Baptist Hospital East, which since 1995 has had a fully functioning endovascular OR suite and functioning endovascular program started by Drs. Edward Kinney and Rick Mitchell. We have also got one of the only fully functioning specialized nursing units in the country for these procedures. Our group itself has had experience with multiple trials, and starting in 1995, only 3 years after the first one was placed in the entire world, has one of the most complete histories of endovascular repair in the country. Today's graft that we'll be using is the Gore Excluder stent graft. This stent graft is placed through small incisions in the groin up into the body, deployed serially, and actually then assembled inside of the aneurysm so that when flow goes through the stent graft, the area of the aneurysmal degeneration or swelling of the artery with the weakened wall is no longer pressurized. Flow still gets to the legs without any difficulty, but the person has no chance for rupturing this aneurysm. Right now we're going to go live to the OR to speak with Dr. Herman Kaepnick, who's going to introduce our team, and then to Dr. Elizabeth Rachel, who's our surgeon today for this aneurysm repair.
Welcome to the operating room here at Baptist East. As you'll see, we have a fully functional operating room, which is also fully functional as a radiologic suite. To introduce the team that we have here today, I'll start with our surgical scrub nurse, Cheryl Dunlap. We then have Mr. Cray Augsburg as our surgical technologist. Next to him is Valerie Thompson, our surgical first assistant. Dr. Dean Wickel behind her is the assistant for Dr. Rachel today. At the head of the table is Dr. Stan Lee giving anesthesia. On the far side there is Ms. Lola Reeder. She's our radiologic technologist. And then, of course, Dr. Elizabeth Rachel, who will be our head operating surgeon today. Dr. Rachel, can you catch us up with where we're at in the procedure?
Well, our patient today is a 78-year-old woman with a family history of abdominal aortic aneurysm, and we've been following her for about 3 years. And in the last year, the aneurysm has increased in diameter to about 5 centimeters. At this point, we've prepared her for the endovascular aneurysm repair. We've made oblique incisions in both groins, and we have accessed the common femoral arteries on both sides with a needle and a wire, which we've passed under fluoroscopy to the proximal descending thoracic aorta. We have an 8-French short sheath in the left common femoral artery and an 18-French long sheath in the right common femoral artery, and we'll be preparing to load the primary trunk ipsilateral stent graft body shortly after passing our delivery sheath, and we'll obtain a primary arteriogram for our landmarks. Dr. Young?
Thank you, Dr. Rachel. Dr. Rachel will shortly be passing an 18-French sheath. As you can see, this sheath here is actually an 18-French sheath that will be going up along the axis of a stiff wire. As she does this, we will watch this under fluoroscopy. We can go live now, I think. Yep.
Our technologists here are loading this delivery sheath, and this is going to be the delivery sheath through which we are going to deliver the endoprosthesis. It has a radiopaque marker on the proximal tip and a large dilator to help guide us over the stiff wire, which is going to act as the platform over which we're going to deliver this endograft.
Dr. Rachel, the advantage of placing the sheath to place this device helps get through very tight arteries as well as taking turns that other devices may not. Is that correct?
That's absolutely correct. The Gore endograft is a unique device in that it's packaged on a delivery system, but not encased within a delivery sheath primarily. So it is one of the smallest endografts that we have available to use, but we do have to get a delivery sheath to the target site.
We're going to switch back to the camera here for a second and look at this endograft itself. We'll be showing you how to prep it in a few minutes, but as you can see, the endograft is housed in a casing of PTFE or material that keeps it from expanding until ready. There is a deployment line that is hooked to this pull line here and runs up the side of the graft, and as you can see on the graft itself, there is a radiopaque marker that Dr. Rachel will be showing you under fluoroscopy in a few minutes that shows you where this contralateral or short leg will lie. We're going to actually place this graft up into the aneurysm and be ready to deploy it when Dr. Rachel is. She will actually be placing hers up through a sheath. We're going to avoid that step for now. We're going to pan back to Dr. Rachel so that she can show you or actually Dr. Kavnick, so they can show you the prep of the device and then actually show you where the positioning is for that short leg.
What we do is we place our graft on the back table. As you see, we have a preparation table that has an L configuration, which allows for a continuous sterile field. The important part of the prepping of the graft is to first place additional sterile gloves over the operating gloves. At the end, there is a metal mandrel which has to be removed from the graft. Once that's removed, then the remaining graft can be irrigated, which will allow for lubrication of the graft and allow for passage of the catheter over a wire. We have a flow switch which occludes the open end once it is flushed. At the completion of the flushing, at this point, using our sterile gloves, we place the graft under fluoroscopy, and this will allow for a positioning or identification of the ipsilateral and contralateral limbs of the graft.
Dr. Young, I think we're ready for fluoro at this time. We're going to be orienting the graft outside of the patient now. Our radiology technician is going to give us a magnified view, and the two radiopaque markers, which you see in the middle of your field now, are identifying the contralateral and ipsilateral limbs on the aortic endograft. And on the fluoroscopy screen, on the left-hand side, you see the long marker, and that is on the patient's right side. So this is going to be our appropriate orientation so that we can have our short leg on Dr. Wickel's side of the table. Dr. Young, I think we can go back to you now while we're loading up our device.
Excellent. Here with me is Liz Cook, one of our scrub technicians. Liz is actually trained specifically with these wires at Baptist to be able to use these devices and handle the back table. It's actually a skill that most of the time is seen with radiologists and radiology technicians. As you can see, here is our deployment handle, and with the deployment line in a direction that will allow the contralateral leg to come out so that we can access it, we're going to now deploy in our model. We focus up on our model. We'll deploy fairly slowly so that you can see it come out. If you can imagine that the kidney arteries are near this top rubber band, we're going to actually deploy by stripping the retaining sleeve, and it deploys out straight like that. All right, we're going to go back to Dr. Rachel and see how close she is.
We're just positioning our endograft here within our delivery sheath primarily, getting our orientation appropriate. And now I'm going to pull back our
Let's go
delivery
ahead and
sheath.
go to fluoro if you can. There you go. So Dr. Rachel is pulling back the sheath so that it approaches the back of the deployment device and doesn't catch the entire graft when it deploys. Why don't we come off fluoro and show the operating field briefly so that we can see where that is.
Dr. Young, if you can go back to fluoro, at this point we're going to be centering on the proximal aortic neck, and we're going to do an arteriogram here to image the renal arteries because that's going to be our proximal target landing zone for the endograft. You could rotate 10 degrees craniocaudal. Can you step back, please? Dr. Lee, can you hold respirations, please?
Very nice picture. While Dr. Rachel sets that, we're going to actually try to point out some of the anatomy on this run. Wes, can you go to a last image hold so we can mark this? Okay, there, please. Now watch the cursor. We'll go first to the left renal artery. Right there, and then to the right renal artery. As you can see, the long segment of normal aorta extending down below the kidneys. And then show everybody that long marker that marks the top of the contralateral limb, right there. Down further, you can see the gold ring that marks the bottom of the contralateral limb that will deploy out when they're ready. Okay, let's go back to live fluoro and back to Dr. Rachel.
Thank you, Dr. Young. We've got our magnified view here. We're going to be pulling down our pigtail catheter so that we don't entrap that within the aortic neck.
Dr. Rachel, for 1 second,
yes.
On that larger view, you can actually see the aneurysm itself.
Yes, we can. You can see the calcification in the aortic wall, and now the pigtail catheter is sitting just at the shoulder of the aneurysm itself. And we've marked the position of the renal arteries. Up, Mag. And we're going to pull our whole delivery system back to our target proximal deployment site.
The image is coming out a little bit darker than we have here in the room. We hope that the viewing audience can see what we're talking about.
Okay. Go ahead. Dr. Wickel is now releasing the constraining tape, and we're actually going to deploy the main body of the graft. Yeah. Very nice. Take the delivery system out.
Excellent job. Very nicely deployed.
Now I'll take the aortic occlusion balloon, please.
Next, Dr. Rachel will be placing a balloon up to balloon the proximal anchors, which, let's switch back to the control desk here. Can we switch back to the moderator desk? Thank you. We actually have, if you can zoom up, anchors on this stent graft. The gore excluder has a positive fixation system. I'm trying to get to the PowerPoint slides that will allow you to see it a little better. The anchoring system needs to be fixed by actually ballooning the area with an elastomeric balloon at the completion of the first deployment. We do this before we actually place or cannulate the contralateral limb. We'll go back to Dr. Rachel, I think, is probably ready for angioplasty.
We're going to set the proximal anchors now. Dr. Wickle's going to inflate the elastomeric balloon just to profile here to set those anchors in the artery wall.
Excellent. While you're doing that, Beth, or Dr. Rachel, I'm going to actually answer some of the first questions coming in on the internet. First question here is, what percentage of people who have aneurysms as large as 6 centimeters or larger die from them bursting? Well, the risk of aneurysm rupture is directly related to the size of the aneurysm. The bigger the aneurysm, the higher the chance of rupture. And at 6 centimeters, your risk of rupture is somewhere around 8% per year. That, of course, is additive over time. At 7.5 centimeters, risks can be as high as 15 to 20% per year. We begin to fix aneurysms around 5 centimeters, which is where the risk of the rupture becomes higher than the risk of the surgery. I think Dr. Rachel's getting ready now to try to cannulate the contralateral limb. We're going to focus on our model briefly to talk about this while they get things ready, and then we'll look at their fluoroscopy. Let's go back to the control unit for 1 second. If you can see our model, there is a contralateral limb here. In this case, it's not fully expanded because it is not very warm in this area, and this nitinol metal that these grafts are made of actually needs heat to expand. But she'll be placing a wire up through that to allow us to first ultrasound using an intravascular ultrasound and then actually deploy a contralateral limb. Let's go back to see the fluoroscopy and see where they're at with that. And during that time, we'll have Dr. Kabnick comment on the intravascular ultrasound unit in general.
At this point, what we've done is load a small angled catheter over the contralateral wire, which is on Dr. Wickle's side, and he's going to maneuver the wire into the contralateral leg. And once we gain access to that contralateral leg, then we will be doing an intravascular ultrasound to take an appropriate measurement of length and diameter to determine the contralateral piece that will be put in to, in fact, complete the endograft, as this is a modular system that, as Dr. Young had indicated earlier, we assemble within the aneurysm itself. So it is, in fact, a semi-custom device that we measure for each patient as we're doing the repair.
Now, this part of the procedure is somewhat scary to some physicians who don't do it often, but in reality, it's really not that difficult. There are a lot of techniques usable to do it if you can't get it. Dr. Wickle and Dr. Rachel, of course, got it right away. Could you talk just briefly about some of the techniques that would be employed if you can't get there?
We use a variety of techniques and a variety of directional catheters to rotate us into the appropriate three-dimensional space. Obviously, the image intensifier gives us a 2D picture of an aneurysm that can be not only moving left to right within the patient's body, but anterior to posterior. So we will occasionally move the image intensifier into a different projection to see if we're in front or behind the graft, or we use a different directional catheter. And even on rare occasions, sometimes we will cannulate the trunk ipsilateral limb of the main body and go up over the top and snare the contralateral wire.
Excellent. We're going to actually go to the control unit here, and then as you guys begin to IVUS, we'll want to watch that. We also have a video loop we'd like to play in the interim. We're going to see Dr. Rachel choose a limb. The limb will be passed up safely into this area and then deployed.
Come out again.
And then the whole graft is actually deployed
Give me a
as
tegaderm
needed.
and put it on there.
Why don't we run to the video loop if we can, and then we'll be ready to watch the intravascular ultrasound. Here's the video loop. So this is what you've already seen, the passage of a wire up for the body. Along the wire axis now is passed a sheath.
Make sure your sheath is
That
down far
sheath
enough there.
dilator is removed. Actually, this sheath already has
looks
the graft in it. Now you're going to see the graft deployed.
Okay.
It's positioned at the kidney arteries and
My
opened.
earpiece is out again. Dang it all.
On the other side, a wire is used to select that contralateral gate, which we saw marked by that gold ring.
Tegaderm for my-
Another limb is chosen. Today it'll be chosen based on intravascular ultrasound and then deployed. We're going to go back to you, Beth, or Dr. Rachel, with the intravascular ultrasound.
Yes, clamp. Dr. Wickel is just getting ready to do the intravascular ultrasound, and we're going to choose an appropriate diameter limb based on this IVUS measurement in the right common iliac artery, and our length will be determined by the measurement from the gate of the right limb to the right internal iliac artery.
As the
Go ahead. Let's go all the way up. Okay.
you can see
Lola,
that
can you magnify, please, there on our fluoroscopy image? And we're going to get the image there at the top of the gate of the main device. IVUS back. IVUS back. IVUS back. Right there, please.
now you can see that those legs are splitting there on the ultrasound. This confirms the length measurement. Dr. Rachel, when you're done getting your measurements, can we run back up and just take a look at the top of that graft again
Sure.
for the viewing audience?
Pin the graph there. And pin the ultrasound.
There we go.
There we are within the aneurysm itself on the IVUS. Keep pulling back. Let's get a diameter there at the right common.
Now the Gore excluder has a multitude of contralateral limb sizes that can treat almost any size of iliac artery, including from as small as 12 millimeters up to 20 millimeters. And this patient seems to have a fairly large right iliac system.
That's correct, Dr. Young. We're just going to get our final length here at the hypogastric. Can you push back up, please? Okay.
I don't know, I couldn't hear.
I'm going to scroll back on the PowerPoint slides so that people can kind of get an idea of the anatomy
Where's
we would be
Jeffrey?
looking at. This is not this patient's exact anatomy, but you can see
I can't hear you.
the sign that says the left common iliac artery.
I need the
There's an
18,
artery that
10
splits
length.
just beyond that, and that is the hypogastric artery that Dr.
Yeah.
Rachel refers to
We have the dilator for this. Get the IVUS.
before the external iliac artery that goes down the legs. We'll be able to give you a better look at that when we shoot a run.
Dr. Young, we're going to be going to fluoro here, and Lola's going to set up, and we're going to do a retrograde image through the right femoral sheath and mark the hypogastric artery and do our deployment based off of that. Move up just a little bit.
Right.
I want to see the gate and the hypogastric.
Dr. Rachel, what limb were you thinking of using based on the intravascular ultrasound?
We're using an 18 millimeter diameter, bell bottom, 9.5 centimeter length.
Excellent. And you'll get
Yeah.
full apposition across the gate from the contralateral limb.
Correct. We're going to shoot a run here and mark our hypogastric artery. Dr. Lee, can you hold respirations, please? Dr. Lee? Hold, please. Marker, please.
Excellent. So you can see there that what we call the hypogastric artery, which feeds the pelvis. We'll put a marker right on that. Why don't you go up west and show the contralateral marker and then the bottom of the leg as deployed. There's the bottom of the leg, and there's the contralateral marker. And what we'll be doing, well, Dr. Rachel will be doing, is advancing her sheath up into that limb for deployment. Here we see the sheath advancing.
We're back on fluoro now, and Dr. Wickel is advancing the dilator and the sheath together. Again, we've got to establish a platform through which to get this uncovered graft within the artery. And we're at our target position, and Dr. Wickel's going to remove the inner dilator.
We're going to pan back to the control room for 1 second, Dr. Rachel, to look at what they're going to be seeing under fluoro. This is an example of the sheath, and what Dr. Rachel will be doing is she'll be pulling, or Dr. Wick will be doing, is pulling back that sheath to meet that white marker at the end. That assures that the sheath is back past the deployment sleeve on the gore excluder. The device has already been passed safely into this contralateral gate, and what we're doing is we're getting as much apposition between the new limb and the contralateral gate as possible. That's a full 3 centimeters and has been shown to be very durable. It doesn't dislodge once it's in there. We'll give it right back to you there, Dr. Rachel and Dr. Wickel.
Dr. Wickel and Dr. Kabnick and Cray are prepping the contralateral limb, and again they're going to be putting on their sterile gloves to ensure that we don't have any cross-contamination from the operative field to the stent graft prior to implantation.
While you guys are doing that, we may switch to the computer animation briefly so we can talk about why the pictures don't always look the same as the CAT scan.
I think that actually would be a good time to do that right now, because we'll be getting ready to prep our contralateral limb, and we'll give you the sign at that point. I'll help you. Left. Other hand.
Yes, you're waiting for the graphic. Yeah. Okay. This is a 3-dimensional reconstruction of an aneurysm. As you can see, turning it on its axis, this aneurysm is quite large. However, when you take away the clot that forms inside these aneurysms, which is represented by the yellow, you can actually see that on a plain X-ray using dye only, this aneurysm may not look nearly as impressive. It doesn't make it any less dangerous, however, and that clot that does form inside these aneurysms can indeed cause problems of its own, especially when wires and catheters are passed through, and can be somewhat dangerous. This computer program itself is quite useful and actually has the ability to put a virtual gore excluder graft into this aneurysm, which we may do later in the broadcast if we have time. We're going to flip back over to fluoroscopy with Dr. Rachel now, which I think they're ready to go with the device.
That's right, Dr. Young. At this point, we're on fluoro, and we are passing the contralateral bell-bottom limb up inside the trunk ipsilateral main body. And now Dr. Wickel is pulling back the delivery sheath to expose the graft. And we've marked the position of the right hypogastric artery, and our graft is lying above that. So we know we've preserved flow there, and we're going to pull back this contralateral limb to the target position prior to deployment. We're getting ready to deploy here. We're just going to remove the constraining tape, and our contralateral limb is deployed.
Excellent. We're going to flip over real quickly and answer some questions that have come in on the email. The first I'd like to address is the fact that some people may be having trouble with their feeds, their audio and video feeds. If you can, there should be a help button on the website. We suggest that you start there with pressing that. Several other questions of interest. First, aneurysms are definitely inherited, and a question comes from a patient whose family has 4 aneurysms out of 10 people. Is there anything that they can do to prevent them? Well, genetics are certainly an issue with aneurysms. There's between a 10 and 20% increased risk with a first-order relative who has an aneurysm. There is no good data on what we can do to stop aneurysms. We do know that smoking does promote growth in aneurysms. We know that atherosclerosis and hardened arteries, cholesterol are also related. Some people who have theories on aneurysm development think that things like certain enzymes are promoting breakdown of the artery wall. A lot of research is being done, nothing proven yet to be helpful in preventing aneurysms, however. The next question that comes is, before the Gore excluder, how are aneurysm repairs conducted? We'll actually flip through some slides to talk about that in 1 second, but as you can see on this PowerPoint slides next to this live presentation, we actually made an incision on the abdomen, cut down, clamped the artery, and repaired it open with some fabric, including a Gore-Tex bifurcated graft that we would sew in to different positions in the artery. This is a procedure that's been tried and true, been done for a long time. It's an excellent option, but it is every bit as big as open heart surgery as far as surgery goes. Dr. Rachel, are you close to being ready to ballooning the gates?
Yes, Dr. Young, if we go to fluoro right now, we've got our balloons in place, and we're basically getting ready to iron out both of these limbs by inflating these balloons within each leg of the graft. And we've got one balloon in the graft-graft interface on the right-hand side, and the other one in the primary limb of the graft. You can drop them. And we're going to march our way down through each one of these limbs, inflating our balloons and essentially just ironing out these legs.
Excellent. While you're doing that, I'm going to answer some more questions. We'll stay on fluoro, however. The next set of questions is interesting. One question was, with the undilated balloons, how large are they? Well, we measure everything in French size, and most of these balloons are able to be compacted down very well to get up through a relatively small area or a small tube. Since the tubes we use for this are of moderate size, we usually don't have any real problems with them. The next question is, why are some aneurysms larger when seen on CAT scan than when seen on ultrasound? Well, ultrasound is an excellent screening tool and is the first study to be done on all aneurysms because it's non-invasive and uses no dye. However, the most accurate measurement for diameter is truly the CAT scan, and if possible, with 3D reconstruction. We had a problem with getting a feed from a company here in town called 3D Reconstruction, or 3DR, but they have excellent technology these days to reconstruct aneurysms off of CAT scans, as do many places in the country. We're going to go ahead and flip back over here and see, it looks like we're done with the dilatation. Let's talk briefly about our PowerPoint slides. This is an example actually of an aneurysm in the femoral artery that has been subsequently repaired with a Gore-Tex interposition graft, or sewn in with a basically a suture to the native artery. That is basically what's done for the open repairs. I'm going to backtrack here to talk about the origin of open repairs, and then we're going to talk about stent grafts in general and the Gore-Tex, or the Gore excluder in particular. The first time that open aneurysm repair was reported was in 1951 in France. Since then, DeBakey, who a lot of people have heard his name in the U.S., developed his own fabric graft that he implanted in people successfully. This is a 20 to 30 year repair that's done on people these days. It does require significant time in the hospital and oftentimes in the ICU. Stent grafts themselves were developed in 1992 when a surgeon in Argentina theorized that it would be less morbid to place something from the groin across an area that possibly may not be accessible even by surgery. And this turned out to be quite the case, with a significant number of companies developing grafts in fairly rapid succession. The Gore Excluder is a long-term graft that's been out quite a while, with over 20,000 or approaching 20,000 implants worldwide, has had excellent statistics, and has had a very good success rate at treating aneurysms. When an aneurysm is treated with a stent graft, it's basically being treated with a combination of a stent, which you can see on our PowerPoint slide, combined with the Gore fabric made of expanded polytetrafluoroethylene. This fabric is actually able to seal the blood off from the aneurysm as it flows through the stent, and thereby excluding the aneurysm from the circulation, hence the name Excluder. As you can see, with the first implant in 1997, FDA approval for general use in 2002, and only 3 ruptures once the graft has been in place, with approaching 20,000 implants. This is an excellent graft. I'm going to switch back over and see where we're at with the operating room here. I believe we're ultrasounding now.
Dr. Young, we're back on IVUS, and we're imaging both limbs of the endograft at that point. Can we have a diameter there? This is the proximal left limb. And we image using 2 modalities, intravascular ultrasound and angiography, after implantation of the graft, because that gives us a more complete picture of the diameters that are available for flow, and we want to make sure that there's not any AP constriction of the graft that we wouldn't appreciate necessarily on a 2-dimensional arteriogram. Can I have a diameter of the distal left limb, please? Okay, good. This also gives us the ability to look specifically at the access vessels and ensure that we have preserved flow to the internal iliac artery in the pelvis, and to look at the external iliac artery and make sure that we don't have to repair an injury that was necessitated with passage of the large delivery sheath. And our left access system looks perfectly fine. And we're going to prepare to transfer the intravascular ultrasound now to the right side. So it might be a good time at this point to take another question.
Excellent. We have one that pertains to the Gore Excluder and what are some of its advantages, and what Dr. Rachel was just talking about is clearly one of them. With the relatively small size of this graft, when it's compressed down into its sleeve and placed through a very safe sheath, we are able to treat people who have fairly small access vessels. And that's really been a very big benefit, especially to women. While aneurysms are very prevalent in men over 60 years old, women are still certainly at risk, especially with family history, and should not be ignored for screening. What we know, other advantages that we feel that this system has, is obviously the anchor system at the top prevents migration. Many times with the flow of blood pounding against these grafts, certain grafts have a tendency to move over time, and that has not been a problem with the Gore Excluder. I'd like to talk a little bit about a screening program that we've instituted with the help of Gore, the Gore company. Liz, would you grab that off of the wall there? Our screening program. We've actually been able to offer to the general public in this area an opportunity to be screened, especially if you have a family member who has had an aneurysm and or any of the risk factors that do include smoking, being heavy in weight, or having high cholesterol. Those are all reasons to be screened, especially if you're approaching the age of 50. Certainly this disease known as the silent killer is not going to show itself till it may be too late. let's see where we're at with Dr. Rachel, and then if we have time, we'll answer another couple of questions.
Thank you, Dr. Young. We've completed the intravascular ultrasound of the right limb and confirmed that we've got appropriate diameters and no injury to the external iliac artery. And we've repassed our pigtail catheter into the artery through the stent graft, and we're now going to take a picture, our completion arteriogram, hopefully, and we will image the stent graft itself and the native vessels.
Great. They're going to set up for that. We're going to answer this next question. Are all patients with aneurysms candidates for endovascular techniques? At this point, no, unfortunately. There certainly needs to be several anatomic criteria to have a stent graft. We're going to flip back and run that fluoroscopy there, or actually is running good. I'm going to talk about that in a second here. Let's run that through a couple more times, Wes, so people can see it live, and then we will stop the image and put the pixels right on it. As you can see, here's flow of contrast. Both kidney arteries are widely patent. Position is good. There's an area of flow still into the aneurysm at the very top that we'll be looking at again probably with the balloon. You can see flow down into both of the limbs, and both of the what they call hypogastric arteries or internal iliac arteries are widely patent. So we have a widely patent stent graft here with good flow into the legs. While they re-image that area and get ready to treat that proximal area, we're going to go ahead and pan to our
Up a little bit more.
Our PowerPoint slides again here real quick, if you can come back. They're going to actually leave it on the floor. They're actually ballooning again here. They're going to balloon now fairly aggressively at the top and kind of down at the body. Based on our measurements, we should get a good seal with this graft. When we have done grafts on people who have very short necks or angled necks, that has been a problem, and that speaks to the question that was just asked on the internet: are all patients candidates? Certainly, we hope that over time stent grafts will actually be usable on 90% plus of people. Right now, we think that somewhere around 50% of patients are candidates, and it really depends on whether they have enough normal artery above the kidney or below the kidney arteries before the aneurysm, and whether they have good normal artery down in the iliacs to seal to with these bifurcated devices.
Okay.
We're going to actually, Wes, are they still fluoro? We can't really put the cursor on right now because of that. So I think what we will actually do is go ahead and once again review the device itself. As you can see, it's on the PowerPoint, is actually a modular device that comes out of the constraining sleeve. You saw that. We saw it going up. We've already run our animation. Here we go. Here's some examples of what we will expect it to look like when we get done on the PowerPoint. Are we able to go to? No. Okay. Let's look at the.
Dr. Young, I'm just going to pass a second wire up here, and we're going to repeat our balloons distally, and then I'll give you back the floor, and you can look at your PowerPoint animation.
Not a problem. We'll keep working with that. And as you can see on the PowerPoint on the right side of your screen, this image shows the preoperative evaluation of an aneurysm with a large area right at the mid-segment of the lower aorta. The graft has been placed on the right side of the image, and you can see that there's flow only in the graft, and the aneurysm itself is excluded. Here's another image of a complex aneurysm with plaque and clot in it that has subsequently been treated with a Gore excluder. Do we have any other questions here? Let's take a look. A question comes in: how many excluder devices has our practice been involved in implanting? We're approaching around 200 grafts here with the excluder itself. Why did we choose the excluder for this patient? We obviously think of it as an excellent graft and has the proximal fixation system, which we believe has become very important. The anchors, I think, are important to prevent migration down the line. What is the question of, well, there's no question, but we do have a incidence of what's called endo leaks in stent graft repairs. The trade-off to get a procedure that's done minimally invasively with a one-day hospital stay and an immediate return to activity and really very little post-operative morbidity does have a trade-off in the sense that about 1 out of 20 people will have some type of blood getting back into the back of an aneurysm. The majority of this type of leak that occurs, or endo leak, comes from arteries that come in the back of an aneurysm and are actually seen with sometimes what's called the inferior mesenteric artery. You know what? I think the best way to describe this would actually be to go back to our computer animation briefly while they're doing this ballooning. And Dr. Rachel will let us know when we're ready to shoot our next picture. Okay, we're going to get that computer animation up here in a second. As the blood can be coming back into the back of that aneurysm, you can see on our computer animation that blood is fed out of these aneurysms to other blood vessels. And I'm putting the cursor on what's called the inferior mesenteric, inferior mesenteric artery that feeds some of the small intestine. Occasionally, blood can actually come backwards from the small intestine into the aneurysm sac despite having a graft seated inside this aneurysm and excluding the majority of flow. If that occurs, it's usually not a problem. We usually do see these aneurysms shrink over time with a graft in place. If they stay stable, however, we also consider that not a problem and actually a good seal and a good treatment. If the aneurysm were to expand over time with the graft in, then we would go looking for sources. The issues with regards to other endo leaks do include what's called a proximal endo leak, where blood can come from the top of the aortic neck down into the graft, next to the graft, or distal endo leaks, which can occur from the bottom. And those are both a little more concerning, and we do our best to treat those aggressively. I'm going to go ahead and transfer down through this, this 3D reconstruction here for you so you can see why a CAT scan may help with this. Here you see on the left side of this 3D reconstruction the area of contrast inside the flow channel and the area of what looks like an egg white and egg yolk. This area of darkness here is actually neural thrombus that layers the inside of this aneurysm in the body's attempt to keep the flow from pooling in the aneurysm. I'm going to show you actually where this CAT scan slice is reconstructed within this model right here. And you can see clearly that it's very nice technology here. We'll actually make that thrombus a little less visible so you can see how it is correlating with what you're seeing over here. When you do an arteriogram, what you're really seeing is the flow of blood, which is represented by this, by the red flow on this model right here. We have another question now while I'll spin this aneurysm a little bit while we answer. Yeah. Wow, we're getting quite a few questions actually. Let's start at the top here. This is actually from a patient from Belgium. What could the complications be, and could you explain what an endo leak is and how could it happen? Well, as we've been talking about, the endo leaks are what we consider to be the one of the things we have to watch for long term with these grafts. The truth is that once you have a graft in place, you will need to be monitored for life. Usually on a 6-month basis. Once the aneurysm is shrunk down to a very small size, we usually switch to yearly. Monitoring comes in 2 forms. One is a CAT scan and one is ultrasound. We have a high confidence level in our ultrasound techs at our office, and we do use them quite a bit, but we also spread some CAT scans in with them to try to make sure we don't miss anything. Like I said, we have a 95% fix rate once we've started. So getting this aneurysm sealed to start with, and then keeping it sealed doesn't seem to be a problem with the right patient choice. The endo leak, like we said, is when a small amount of blood gets into the aneurysm sac from sources either around the edge of the grafts or back in from behind the grafts with these small lumbar arteries or the mesenteric artery. Do we think of any other complications? Well, obviously we do make an incision in the groin, so there's also some small risk there, but it is really a good technique for most people. I think we have another fluoro run here being done. Let's take a look at it here. Obviously both kidney arteries fill well. There we go. Good. Just a tiny little bit of blush into the top of the aneurysm sac, but really a very good seal zone at all sites. Let's see if why don't you go ahead.
Dr. Young, we're just reviewing the arteriogram here and
Okay.
looking for some of those collateral blood vessels which you've mentioned, which can feed the aneurysm sac retrograde. And we'll just be paging back and forth in here. You can see some of the iliolumbar vessels at the distal aspect of the graft feeding off on the right-hand side in particular.
Yep. Can we freeze that and kind of show that with the pixel cursor for just 1 second?
You'll have to page forward a little bit farther into the run.
There we go.
There is a collateral vessel you can see at the top, at the neck, at the aortic neck,
Right.
and one at the distal
Right up
aorta
there.
at the bifurcation.
Now, these vessels could be either feeding the aneurysm from below, or they could be being fed by
Let's
the
do one more
aneurysm still,
proximal
and that's
below.
what we're trying to decide between,
Okay.
isn't it, Dr. Rachel?
That's correct. I think at this point what we're going to do is take our proximal balloon up one more time, reset the neck, and take our final picture.
Okay, great. It certainly looks like the deployment is right on the renal arteries, and certainly there's no room to put a cuff in up above. Perhaps an oblique view may also help determine if there is a flow coming from one of the lumbar vessels in this nice lady. You can also see the kidney arteries filling the kidneys quite well in that view. Go ahead. We're going to go ahead and answer a couple more questions while we have a chance. How would you know you have an aneurysm developing, and are there signs or symptoms? Unfortunately, no. For the majority of people in this country, our waistlines are a little too big to even palpate an aneurysm until it gets to be quite large, meaning that if you are of a waist size of approximately mine, about a 38 or a 40, your chance of feeling that aneurysm is pretty low. Certainly, family history is a big part, but clearly, I think your best chance is to get a screening exam when you approach 60, or if you have a family history when you approach 50, and then if you're negative, you probably only need to be screened once every several years. Aneurysm growth rates are very slow, relatively speaking, under a half a centimeter a year in general. And if you do even have a small aneurysm, a 3-centimeter aneurysm per se, it may not grow for many, many years, and it may take a long, long time to develop. Oftentimes people come into the office saying, well, I have this aneurysm, it's 5 centimeters, we need to fix it emergently. But you have to point out to that person that that aneurysm has really been growing for many, many years inside them, and that a proper workup to make sure they don't have heart disease or other risks is certainly worthwhile. Let's take another look here. What are the success percentage of women versus men for endovascular repair of aneurysm? Excellent question. Really, the early devices that were made were quite large with regards to the size of the graft going up through the iliac arteries. And it really was quite difficult to treat women who, generally, do have smaller access vessels. I believe that the Gore excluder is really the first graft to address that, and has become quite useful for treating women with smaller vessels. The risk of a woman developing an aneurysm, as we said, is a little less than a man, but certainly not enough to ignore it. We're going to take our last run here because I think we're running out of time. There's still a little bit of flow. Okay. I think we have a good improvement in that area with the repeat angioplasty. I think certainly there's still a little bit of flow, but I believe that will probably seal itself off. We'll kind of go back to the room here in a second once they get done evaluating that area.
We're at the top of that limb.
In the meantime,
I think it's graft here.
is endovascular repair of aortic aneurysms now the standard of care? I think that question is actually a fairly loaded question. There are a lot of people who believe that it is. There are a lot of people who believe that open repair is still the standard and endovascular repair is still somewhat early in its use. We have been doing it for 10 years and have found it an excellent option to treat people long term. I will tell you that with regards to all things being equal, if I were to have an aneurysm and I had good anatomy for a stent graft, I would prefer to have that done with good monitoring over an open surgery. Certainly if you don't have good anatomy for the stent graft, then an open repair is a very valid and excellent option. And we do both here, and we do them at a high level of success. So we do believe that they both have their place. Sound like a politician there, not really giving you an answer, huh? One patient has actually mailed in a question very specific. They must have either an aneurysm themselves or a friend talking about sizes and an angled neck. I would really stress that you get someone to look at the films and give yourself the best option. Go to an institution that has experience with these endografts and can tell you whether or not you or your loved one has an option for a stent graft repair. Certainly, we believe that if it can be done, there should be a place fairly near you that can do it. So, all right, they're finishing the ballooning and actually redilating a little more aggressively with the 14 balloons at the top. The elastomeric balloon that's used to fix the anchors is not a true angioplasty balloon. It is more of a balloon just to kind of flesh out the graft and seat the graft. So it is what Dr. Rachel's using now are actually true angioplasty balloons that can go up to a significant pressure and compress the area. I think what we may do also at the completion of this is look again with the intravascular ultrasound and make sure everything is well seated. But it sure looks like Dr. Rachel deployed the graft perfectly at this right spot, and looks like we're going to have a good result. We're just going to have to get this proximal flow limited down so that it clots off. Remember, these patients are anticoagulated during the procedures, and that also promotes a continuation of some of this flow into the aneurysm sac that then resolves once the anticoagulation is removed. Do we have any other questions? Looks like here. Oh, I'm sorry. It looks like we had some trouble with the microphones while I was talking about who is a candidate and who is not a candidate. As a referral center for this technology, we oftentimes get referred patients who other doctors think are excellent candidates because they're just simply very sick people who can't have an open repair. The true decision on who's a candidate has got to be made anatomically, or based on whether they have a good neck to seal the aneurysm graft at. I'm going to switch back on our PowerPoint to a X-ray that'll give you a better idea. If I can get there. There we go. That should be coming up on your PowerPoint side in a few seconds. Basically, as you can see, there's a large or a long proximal neck that's normal artery on this. You need at least 1.5 centimeters of good neck to seal with. This patient had 3 centimeters. There we go. As you saw on that run we just did on the live fluoro, the area of blushing inside the aneurysm sac proximally is continually getting less and less, and will soon probably stop altogether as Dr. Rachel finishes angioplasty in that area. So certainly I think we're gaining ground, and we'll be done with this for this nice lady pretty soon. Also, with regards to the anatomy, we need good distal landing zones. So, okay. We certainly appreciate you all tuning in. Dr. Rachel, do you have any comments to make before we sign off?
I think that we've gotten a nice repair, and the anatomy was very favorable. I think that that proximal fill is off of that lumbar, off of the right-hand side. We clearly saw it on that last image, and I expect that with the Gore device that's simply going to stop flowing relatively shortly.
Excellent. Well, we'd like to thank you all again for viewing. The archive version of this program will actually be available shortly on OR Live, and you can watch it at your convenience. We appreciate all the questions. We had quite a few here, so I do think that certainly this is an excellent forum for these questions, and I applaud all the people who watched, because taking part in your own health care via information services has really become, I think, the patient responsibility. So thank you for tuning in.
This has been a live webcast of an endovascular abdominal aortic aneurysm repair with the Gore excluder bifurcated endoprosthesis from Baptist Hospital East in Louisville, Kentucky. For more information, to make a referral or make an appointment, click the buttons below.